A very good evening to all the attendees who have joined for this meeting. So this will be the national classroom session of Spice Route India Movement, which is the Young Doctor Forum for Family Medicine in India. So we have been conducting classes every month for the last so many years. And for the March 2026 session, we have chosen one of the OBG cases to be presented for our clinical session. So the session will be hosted by Spice Road Kerala chapter, and this is indeed the last session of the ongoing state chapter of Spice Road Kerala. Spice Road Kerala have been conducting regular sessions, and this class will be moderated by two of the eminent faculty members, Dr. Aishwarya Lekshmi J. She is the Assistant Professor, Department of OBG, Government Grand Hospitals, Mumbai. And the co-moderator will be Dr. Shubha Achyutha. She is the Associate Consultant and Coordinator, Department of Family Medicine at VPS Lakeshore Hospital, Kochi. And the case will be presented by Dr. Haifa, Abdul Hakkiem. She is the Family Medicine Resident at VPS Lakeshore Hospital, Kochi. Over to the moderators to take forward from here on. And over to Haifa for the presentation. Thank you.
Good evening, Dr. Vishnu. Good evening, Dr. Aishwarya, and to everybody. Thank you for the introduction. On to Dr. Lekshmi and Dr. Haifa.
Yeah, good evening, everyone. I'm Dr. Aishwarya Lekshmi. So I have the today's topic for presentation is gestational diabetes mellitus, which is a very most common disorder of pregnancy that we are seeing. So let's see the case, and then after that we'll have a detailed discussion on the above. Okay, over to Ms. Haifa.
Good evening, everyone. Good evening, ma'am. Good evening, Shubha, ma'am. Today we have obstetric clinical case presentation. I am doing the session on behalf of Spice Road Kerala chapter, session March 2026. My patient is Mrs. ABC. She's a 30-year-old female, a BCom graduate. She's a homemaker. She hails from Panangad, Kochi. She's Muslim by religion, married to Mr. XYZ for 8 years. He is a shop owner, educated up to BCom, and they belong to upper middle social economic status. Gestational score is Gravida 5, Para 1, Live 1, Abortions 3, with previous normal vaginal delivery 6 years ago. Her blood group is O positive. Last menstrual period was on 31st May 2025, and expected date of confinement is on 7th March 2026. Current gestational age is 38 weeks, 3 days. She is now admitted for safe confinement. No history of pain abdomen, leaking PV, or bleeding PV. She is able to perceive the fetal movements well. History of present pregnancy. First trimester.
It was Haifa, so just tell me two named vaginal signs that you see in pregnancy.
Ma'am, bluish hue of the named vaginal signs.
What is it called? Bluish hue of vaginal wall?
Bluish hue is seen. Then there will be softening of the cervix. Then I'm sorry, I won't remember the exact names.
So the bluish discoloration is Chadwick sign.
Chadwick sign.
Correct, it is Chadwick sign. So, and what is Osiander sign?
Osiander sign is
it is
increased pulsation.
Yes, pulsations. Yes. Seen where?
Increased pulsation is seen on the lateral wall of the vagina.
Correct. To the lateral fornix. Okay, Haifa, you may proceed.
Okay. So she conceived spontaneously and pregnancy was confirmed by UBT after 15 days of missed periods. Routine antenatal blood and urine tests were done and were normal. Early pregnancy scan, that is the dating scan, was done at 8 weeks. Confirmed live, single live intrauterine gestation corresponding to period of amenorrhea. Folic acid supplementation was taken. She gives history of nausea and vomiting, 2 to 3 episodes per day, which was managed occasionally with medication. No history of admissions for the same. Nuchal translucency scan was done at 12 weeks, which showed normal NT. No history of fever with rashes, pain, or increased frequency of micturition. No history of abdominal pain, bleeding per vagina. No history of exposure to radiation, regular drug intake.
Can I interrupt? That
Yes.
when you're giving the history of the present pregnancy or whichever part of the history it is, if it is from it is from the words of the patient. So when you are using ondansetron, it's fine since the patient is a BCom graduate, but better try to avoid that in the history. Okay,
Yes, ma'am. Okay,
fine,
ma'am.
you can continue.
Second trimester, cervical cerclage was done at 14 weeks in view of previous 3 pregnancy losses due to cervical insufficiency. Quickening was felt at 18 weeks, started on iron and calcium supplements. 75 grams OGTT was done at 28 weeks, concluded high blood sugar values of 190 milligram per deciliter after 1 hour and 130 milligram per deciliter at 2 hours. She was advised medical nutrition therapy. 2 doses of tetanus toxoid injections were taken 1 month apart. Anomaly scan was done at 19 weeks, showed no gross anomalies. Doppler scan was normal. No history of bleeding or leaking by vagina. No history of elevated BP recordings. Bilateral lower limb swelling was done, but it relieved with rest.
Okay, one more thing. When you're mentioning about the iron and the calcium supplementation, it's not only about starting the drug. You have to tell whether the patient was regular or on the same or not. Sometimes we might start on the drug, but the patient might not be compiling that the compliance to that will not be there. So that also you have to mention in your history. Okay. Yeah, fine. And one more thing is you have mentioned about 75 gram OGTT was done and it was deranged. But the protocol wise, after 2 weeks, once you have started on your medical nutritional therapy, you have to repeat your postprandial glucose monitoring should be there. And in the entire trimester, it was done under 28 weeks. So that is not mentioned. I hope it will be in the third trimester. If you haven't mentioned here, it should be mentioned. Since 28 weeks, the second trimester is done. So when you're mentioning about that, the 2 weeks post that, the next value should be mentioned in your third trimester. Okay?
Okay. Fetal movements were perceived well. Iron and calcium continued. Serial blood glucose monitoring was done. She was initiated on insulin at 34 weeks in view of high fasting and postprandial blood sugars, of which the values she is not sure. Growth scans were done at 32nd and 36 weeks, which were normal. Weight gain of 13 kgs in total. No history of burning maturation, increased frequency of maturation or fever. No history of bleeding per vagina, leaking per vagina. Now, can I move on?
Haifa, just tell me, as per WHO, what is the minimum number of antenatal visits? And you've also mentioned all the antenatal steps that were being taken for this patient, but just sum up. So, what are the things that you do as a part of antenatal care?
Ma'am, WHO recommends 8 antenatal visits in total. One is the first, at least at between less than 12 weeks, within 12 weeks, there should be 1 visit. Second visit at 24 to 26 weeks, 2 visits. And after that, at 30 weeks, 34 weeks, 36 weeks, 38 weeks, and 40 weeks, 5 visits. After that, if she has not delivered the baby, then at 41 weeks. That is all. Final.
What is it known as? This kind of 8 visit is known as? There is a particular name given by WHO for the same. It is known as inverted pyramidal care of antenatal visit. Okay, so between preconceptionally, there is 1 visit, which if possible is mandatory to assess the condition of the patient, like any risk factors are there, any congenital problem or any genetic problem there, or any type of that patient is having high risk to. About that, we have to check the patient on that preconception and preparation. That is there. After that, once the patient is pregnant, in 12 weeks, we have to have a risk assessment on that. Then at 20 week for the anomaly scan, and the same way we are doing the same. So it is known as inverted pyramidal care. Okay. Yeah.
Okay.
And that I have mentioned before itself, that insulin you have initiated insulin at 34 weeks, but what happened at the 30th week and 32 week is not there. But if it is normal, the other monitoring is normal has to be mentioned. Okay. That is also because it's a part, like in case of diabetes, till 30 week, we have to have a like 2 weekly monitoring in case of diabetes patient. But since she has been found out to be gestational diabetes by 28th week only, so in 30 week and 32 week she had a normal checkup. That also has to be mentioned, because in diabetes condition the visit is 2 weekly till 30 week, and after that it is weekly. Okay. We usually stick on to this in case of overt diabetes, but as the patient is started on insulin, this also has to be like weekly, and the 2 weekly monitoring should also be started for this patient also. Okay, continue.
Menstrual and marital history. She attained menarche at the age of 14, regular cycles of 25 to 27 days, menstruate for around 3 to 4 days with an average flow of 4 pads a day. Married since 8 years, non-consanguineous marriage, no history of any contraceptive usage. Past obstetric history. Her gestational score is Gravida 5, Para 1, Live 1, and Abortions 3. First pregnancy was after 1 year of marriage, that is 21 years. Spontaneous bleeding happened at around 13 weeks, followed by expulsion of fetus, and was told to be because of cervical insufficiency. Second pregnancy was at around 22 years. Bleeding and spontaneous expulsion happened around 20 weeks. Cerclage could not be done as membranes were protruding into the vagina as per the patient, and dilatation and evacuation was done. Third pregnancy at 23 years, cerclage was done at 12 weeks, but patient developed pain at 5th month. Hence, cerclage was removed and fetus expelled spontaneously, followed by dilatation and evacuation. Fourth pregnancy was at 23 years again. Cerclage was done at 14 weeks. It was a history-indicated cerclage. Normal vaginal delivery was in hospital with a cephalic presentation. Baby weighed around 3.2 kgs, delivered at term, and normal developmental growth. Antepartum, intrapartum, postpartum events were normal for the baby for the last pregnancy. No medical complications were there during the pregnancy.
So for this particular patient, is there any risk factors for having any cervical incompetence?
No, ma'am. As such, acquired causes, no, nothing was there.
Okay. So she was having some congenitally, she might be. That is what your diagnosis is. Since she is having from the first pregnancy, it is. Okay. On about the fourth pregnancy, the stitches that the sutures were removed at term.
Yes, ma'am. Sutures were removed at term.
Because they want to progress the labor. Okay.
Yes, ma'am.
Right. Continue.
Haifa, also just say for all the students who are listening, what is cervical cerclage? Name any two methods that you know.
Cervical cerclage is the procedure by which we prevent the cervical dilatation so that the fetus can be preserved. And there are two methods. The most commonly done is McDonald method, and most common method is McDonald method. I'm sorry, my screen is gone. And the other method is the most common is McDonald method, and second one is modified Shirodkar method.
Okay.
Okay,
so
but what do you do in cerclage?
Cerclage, we are actually in McDonald method. We do put purse string sutures around the cervix so that we are preserving the cervical dilatation, preventing from cervical dilatation. And in modified Shirodkar method, it is using Merceline tape, ma'am.
Okay. On this topic, I'll add some point to that. Cervical incompetence can be. So I was just concluding because usually it's an ops class. So in cervical incompetence, it is like in the early, like in the second trimester, usually there can be first trimester also, and in second trimester also. Usually the cervix, the length is supposed to be around 3.5 to 4 centimeter. But in some patients that the length reduces spontaneously and the patient goes into labor. This can have a congenital cause and an acquired cause. And usually these kind of people are having a previous history in case of acquired cervical incompetence, like previous forceful dilatation of the cervix or any trauma or any surgeries. But in most of the cases, what we are seeing are without any causes, like idiopathic, it has come. So in such cases, as she has said, there are three ways to diagnose, like whether to put the cervical cerclage or not. One is history indicated, another is USG indicated, one is emergency cerclage. History indicated means in this case, like this, there will be previous history of cervical incompetence will be there, like previous history, like no cause, the patient has gone into spontaneous labor before 20 to 24 weeks of pregnancy and the patient has delivered. In USG indicated, usually when we are doing the USG, the normal length is supposed to be 3.5 to 4 centimeter, but in such cases, it will be less than 2.5 centimeter. In multis, we usually take it as 2 centimeter, and in primary, it will be 2.5 centimeters on those cases. And finally, when the patient comes clinically like in labor, in these three cases, we put the cervical cerclage. There can be vaginal method and there can be abdominal method. What you have said is about the cervical method, like we will be putting the stitches through the vagina. There what we are doing is we will put the speculum examination and we will get hold of the cervix, and as high as possible to the internal os, the level of the internal os we go and we put the stitches. Four sutures, stitches will, like the suture is a purse string suture, but the sutures will be taken on all the four walls, and we make sure that the knot is put on the anterior wall or on the left lateral posterior wall. It is for universally we are using that for the ease of identification of the node. And finally, if it is not possible in such patients where the cervix is so pulled up, like adhesions, previous surgery causes adhesion or anything, in that patients we go for abdominal method also. There, as usually we will open the abdomen, like it can be laparoscopic or also it can be opened, and we will reflect the UV fold of peritoneum and identify the internal os abdominally. If you are putting any stitches abdominally, then we have to go for a C-section. And if it is done vaginally, we can go for a trial of labor vaginally. Okay, this is a question usually asked, and if cervical incompetence is a question, then we have to answer all these things.
Ma'am, shall I proceed?
Yes.
Past history, no history of diabetes, hypertension, asthma, thyroid disease in the past, no history of any surgical or medical interventions in the past, no history of allergy to any drugs or food. Family history, history of mother is diabetic. Apart from that, no history of any birth of children with chromosomal anomalies or birth defects.
When in past history, just mention about any history of PCOS also, because that also have insulin resistance. So in your history, that should also be there.
Okay, ma'am.
Most of them are having, so just mention about it.
Okay. Personal history, she takes non-vegetarian mixed diet. Sleep appetite is normal. Bowel and bladder habits are regular and no addictions. Socioeconomic status, head of the family is a husband and he's a sole bread earner. It is a nuclear family which comprises of the husband and wife with one child, belongs to upper middle socioeconomic class according to modified Kuppik-Swamy scale, lives in Pakka house, drinks water from well, anti-municipality supply, appropriate sanitation and adequate ventilation. So this is the diet history which I obtained with the 24-hour recall method, which she has been taken after initiating insulin. This comprises of 3 course meals and 3 snacks. Daily requirement of my patient according to her pre-pregnant BMI is around 1800 kilocalories. If we calculate it as 24 kilocalorie per kg, and 78 grams of proteins, but there is a deficiency of around 26.8 grams of protein and 268 kilocalories. Ma'am, can I continue?
Yes, good.
General physical examination. Patient is conscious, cooperative, well-oriented to time, place, and person, moderately built and nourished. Her height is 160 centimeters. Pre-pregnant weight was 77 kgs, and present weight is 90 kilogram. Weight gain in pregnancy was around 13 kgs. BMI with the pre-pregnant weight is 30 kilogram per meter square. Vitals, pulse 78 beats per minute, regular. BP 110/74 millimeter Hg in the right upper limb in sitting position. Respiratory rate is 18 breaths per minute, regular. Temperature febrile. No pallor, icterus, cyanosis, clubbing, or lymphadenopathy. Bilateral pitting pedal edema is present. Breast, thyroid, and spine were normal.
What is the grade of pedal edema?
Ma'am, grade 1 up to ankle, grade 2 up to mid leg, grade 3 up to knee, and above that, grade 4, ma'am.
Okay, this below ankle is grade 1, below knee is grade 2. Okay, usually we say up to grade 3. Fine. In this patient, what is the grade?
It is below ankle, like at grade 1, ma'am.
Okay. You have to also mention about the skin, hair, and nail in your general examination.
Okay, ma'am.
Usually in this kind of, since you have mentioned patient is having calorie deficit and protein deficiency also, but there can be other deficiencies along with that. So mention about skin, hair, and nail.
Okay. Obstetric examination. Patient was examined in supine position with knees semi-flexed after emptying bladder and after obtaining verbal consent. On inspection, abdomen was longitudinally distended with flanks full. Umbilicus was central with in level with the skin. Linea nigra and stria gravidarum present. No visible pulsations, dilated veins or scars. Hernial orifices were normal. On palpation, fundal height correspond to term. Symphysia fundal height was 36 centimeters. No local rise of temperature or tenderness. First fundal grip, I obtained a hard round ballotable mass occupying the upper pole of the uterus, which is suggestive of a fetal head. Umbilical grip, right lateral grip showed multiple irregular nodules-like structures, suggestive of limb buds. Left lateral grip showed smooth, curved, uniform resistance, suggestive of a spine. And liquor felt adequate clinically. Pelvic grip, first pelvic grip showed soft, irregular, broad, non-palatable structure suggestive of breech, which was felt in the lower pole of uterus. And second pelvic grip was confirmed the findings of first pelvic grip, and the breech is mobile.
It is complete breech or frank breech or footling, what you have felt. The second pelvic grip, but what was your finding?
Ma'am, second pelvic figure, I got the same, it is the breech which I got, ma'am. Mostly it must be the
You were not able to, complete breech.
Mostly completely, but I was not completely able to identify the presenting.
The ventral part, the dorsal part was anterior, like.
Yes, ma'am.
Okay.
Haifa?
Yeah.
Yes, ma'am.
Just explain. So the fundal height corresponding to the weeks, what are the various levels and what does it correspond to?
Ma'am, fundal height in a normal single single gestation, uterus would be up to 12 pubic symphysis at the level of for 12 weeks. Umbilicus 24 weeks and sternum 36 weeks. In between pubic symphysis and umbilicus, when we divide it into 1/3, it is 20 weeks and 12 weeks, 18 weeks, and 20 weeks. And above the level of umbilicus, turning it into 1/3, it is 28 weeks, 32 weeks, and then 36 weeks.
You haven't mentioned about the abdominal circumference. It is very important in case of diabetes. Why?
Polyhydramnios.
Yes, that is it. Because in case, even if it is a GDM, usually by after 34 weeks, there are chances of polyhydramnios, because since the patient is having uncontrolled and then we have to start on the insulin, in those cases the polyhydramnios, microsomnia, and even placentomegalies are very common during in case of diabetes patient. In such patients, very mandatory that you have to take the abdominal circumference.
Yes, ma'am.
And yeah, and also you haven't mentioned about the estimated fetal weight, because what is the most major concern of the diabetes patient during labor? We have to be,
Macrosomia.
yeah, we have to be concerned about the fetal macrosomia. So in such case, what is the formula to identify the estimated fetal weight in from an examination, like from palpation? There is one method to identify. What is it?
Johnson's method simplifies your
Yeah,
fundal height
Johnson's
plus
formula.
12.
Yeah,
Mm.
plus 12. In which patient we will add 12? I mean, we have to subtract
If it is
12.
a term patient, 12 and I'm not
No,
sure.
no, it is not like that. That we have to see whether it is engaged or not.
Oh,
If it
okay,
is
ma'am.
engaged, it has gone inside, then you have to minus 11. And if it is unengaged, then you have to subtract 12.
12,
And
okay.
into multiplied by
155.
155 gram. Usually it is usually overestimated. We will get an extra value, so it's not accurate. But again, in these kind of patients like poly patients, not in poly, like gestational diabetes, and when you have like congenital previous history of macrosomias are there, then you have to mention about that. They
Okay,
will
ma'am.
ask about the questions on this. Okay. Yeah. And any abdominal edema was there or what?
No, ma'am, no abdominal edema.
Yeah. Okay.
Haifa, one more
Auscultation.
thing. One more thing. So while we are on the topic, so tell me in which all conditions the final height will be more than expected and where it will be less than expected.
Ma'am, for both cases, first and primemost,
Hmm.
it could be the wrong dates.
Yes.
Then fundal height can be more than the expected gestation age if it is multiple pregnancy, large baby, like macrosomia and polyhydramnios. And gestational age and FSH less than the gestational age is seen in IUGR, oligohydramnios, um, wrong, and transverse line.
And there is one more condition very commonly seen where you will get more than gestational age. What is that?
Obesity.
Not only obesity, it's full bladder. Okay, so whenever in usually like less than 28 weeks, 24 weeks, when the patient has seen passed urine properly, there can be during pregnancy, patient might have gone, when you are asked them for examination, they might have gone to the toilet, but because of the increased flexion, this compression on the bladder, the urine might not be gone and you will get a bladder there. In such conditions also, you will overestimate the abdominal, like so this usually happen in second trimester. By third trimester, we will not be much effect will not be there, but in second trimester, this can be seen. And also in diabetes condition where you can see the pregnancy with fundal height less.
Over gestational diabetes, the baby can be IUGR.
How? Over gestational diabetes, more chances of macrosomia. Then in which particular condition of over gestational, like over diabetes, you will see microsomia?
If there is preeclampsia associated.
One case is that, another is diabetes with vasculopathy. When mother already has a vasculopathy, the more chances of from the initial time itself, there will be uteroplacental insufficiency or the proper growth, fetal growth restriction will be there. In such condition also, we usually get an IUGM. So
Okay.
since it is a diabetes patient, we cannot assume, like we always have the prejudice that the patient will be having macrosomia, but there are chances with the diabetes there can be IUGRs also. Okay, yeah, continue.
Auscultation. Fetal heart sounds were heard on the right side above the level of umbilicus, regular 142 beats per minute. And speculum and pervaginal examination was not done because the patient was not in consent. And systemic examinations otherwise was within the normal limit.
Patient was admitted for confinement, no?
Yes, ma'am. But since patient was admitted for actually this is an elective cesarean section, ma'am. That is why speculum and vaginal examination was not okay with the patient, ma'am.
There are chances like she is a patient of cervical incompetence. Patient can suddenly go into spontaneous labor. Then one thing you have to rule out, the CPD.
Okay.
Yes, it is okay that the patient is admitted for elective CS, so we will take up the patient. But when you are taking such a case, you always have to keep in mind that there are chances that patient can go into spontaneous labor. By the time you take the patient itself, it might have dilated and causes cervical tears, everything. So in such patients, just keep an eye on the pelvimetry, clinical pelvimetry. You have to keep an eye on that. Okay.
Okay, ma'am.
And even if it is not a previous LSES or anything, like there in if suppose this patient is kept for a normal vaginal delivery, in such a condition, like diabetes is not controlled, usually we will go for C-section, but sometimes not controlled cases, then you should know how to do a clinical pelvimetry and the assessment of the CPD. So there are some signs that you can see from abdominal examination, like Mundroker sign and the clinical pelvimetry. There are some features like how you will assess the inlet, mid cavity, and the outlet. Okay, keep an eye on it.
Okay.
And one more thing, FHS on the right side heard about the umbilicus. Better it is to frame like in the spino-umbilical line. Like you are hearing it on the spine, on the, just in accordance with the umbilicus. So better to say above the right spino-umbilical line.
Okay, ma'am.
The line joining the umbilicus to the spine of the patient. That will be a little more, it will be looking so good when you are present.
Okay, ma'am.
Continue.
To summarize the case, a 30-year-old gravida 5, para 1, live 1, abortions 3 with a female with previous normal vaginal delivery, now at 38 weeks and 3 days of gestation, with history indicated cerclage at 14 weeks and gestational diabetes mellitus on insulin, admitted for safe confinement. On examination, vitals are within normal limit, normal systemic examination with term uterus, singleton fetus with longitudinal lie, breech presentation with the spine towards left. FHS was heard and was 142 beats per minute regular, heard just above the level of spinal umbilicus line.
Can you go to the previous slide once? Here you said you heard the FHS on the right side, and on the next side you said fetal spine towards left. So which one is it?
It is right side. Actually, I wrote left of both, so then I changed there. I forgot to change it. I'm sorry.
Okay, so be careful on this because these are the basics things where the examiner will be particular about.
Inshallah.
Okay.
Provisional diagnosis, 30-year-old, 50, gravida 5, para 1, live 1, abortions 3, now at 38 weeks, 3 days of gestation with history indicated cerclage, present pregnancy complicated with gestational diabetes mellitus on insulin, having singleton live intrauterine pregnancy in breech presentation with good fetal heart sounds, not in labor.
When you are saying about the initial part is fine. When you are giving the last part, the breech presentation, try to say the sacro-anterior or the sacro-posterior like that way. Because you have examined, you know that this sacral promontory, it like you got the bony prominence anteriorly. So that give a better picture.
Okay.
Understood what I have said? You
Yes,
know that this is more towards anteriorly. So the anterior delivery is little more easier compared to when the back is on the posterior. So
Okay.
just modify your sentence. Okay. And so moving on to the discussion, how will you evaluate? Okay, this patient is coming to you. Like you are not the one who is examining her. I mean, so you it is not a book case under you. Then if she is coming to you for the first time, how will you monitor her like at this point of time?
First, I have to make sure, since it's a breech present, two parts I have to take into consideration. The general obstetric condition of the patient, which includes her present blood status, is since she is I'll have to investigate her first to see if she is ready for a normal vaginal delivery or not. For that, I'll have to see her just since I don't have the set of investigations with me. I'll have to start with her normal blood counts, serology level, her serology status, if she is under any infections presently, and also see for that I will have to ask for a urine routine test. Then so these investigations I have to see and see if any scans were done in the previously, if if we are expecting any congenital anomalies, any fetal distress, chances for fetal distress, like if the baby has got any heart disease or anything like that. I'll have to see what has been there in the anomaly scan and her growth scans and all. Then after that, since now she is in 38 weeks of gestation, I will have to, this is a case of gestational diabetes on insulin. So she needs a proper antepartum fetal surveillance. I have to take a CTG initially to see the fetal status. And assess the liquor of the patient, for which I'll need a USG at the current stage.
So what you have to say is like when the patient comes first, I will go through the previous records which is available to the patient. You don't know whether it is a gestational diabetes or an overt diabetes, because might be if suppose the patient is coming from a place like with no proper like she has missed the like some people might identify that they are pregnant, like detect pregnancy after 2 or 3 months and might not have done the HbA1c, or some things can happen when you're working in a tertiary place. So in such cases, first of all, you will go through all the reports and make sure that this is more like a gestational diabetes or overt diabetes, because if it is an overt diabetes, our concerns will be more, and when there is a gestational diabetes, we will be little more happier actually, unless this is an uncontrolled diabetes. Okay, suppose if this patient has come to you at very early gestational age, like what is with this patient, so what are all the sets of investigation that you will do?
Ma'am, in the first, if she's coming at around 8 weeks, is it like that? The first visit,
She
as
is
in
coming to
routine
you with
case?
UPT positive.
If she's coming, I will ask for her routine blood counts, urine routine analysis, TSH, an RBS, and if possible, an HbA1c, and also the serology of the serology, which includes the HCV, HbSAg, and HIV, and that's it.
What does DIPSI says about how
Dipsy,
you will assess any patient who
first.
is coming to you on your first visit? What is the thing that you will do for that lady? Any time of the pregnancy, if they are having the first visit with you, you have to do the
75
yes,
milligram
75 grams GTD you have to do. How you
GT.
are doing that?
Ma'am, irrespective of her fasting status, we'll give 75 grams of anhydrous glucose, which can be taken in 300 ml of normal water or even lime water, and ask her to drink that. And after
Within, within how
within
much
within 10
time
minutes,
she have? Yeah, 5 to 10 minutes. They
5 to
have
10
to drink
minutes.
that water. Okay.
And then we will assess the blood sugar values at the end of 2 hours. If it
Okay.
is more than 140 milligram, then probably she is having gestational diabetes mellitus. And if it is more than 200 milligram, it is supposed to be, we are expecting it to be a pre-gestational diabetes mellitus.
Okay. So suppose she has vomited, then how that diagnosis changes? How you will assess the test?
If she had vomited in less than half an hour to 1 hour, we'll take it at half
Half
an
an
hour.
hour. Yes,
Uh,
not taking that what
uh,
the guideline says 30 minutes. If
uh,
she has vomited within 30 minutes after taking the glucose, then
then we will have to abort the test and ask her to do the test some other day. If it is more than half an hour, then we expect the sugar
you
has
to
been
continue
observed.
the evaluation.
Yes, ma'am.
Okay. 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 Then if suppose there is a value is positive, then
If it is positive, if it is 140 milligram per deciliter, we will ask her to continue on medical nutritional therapy. After 1 week, we will reassess the fasting blood glucose and 2-hour postprandial glucose status. And
Is it 1 hour? Is it 1 week?
1 week.
How it is? How much time we have to wait? Is it 1 week or 2 weeks?
Ideally, 2 weeks, ma'am.
See, when you're saying the guideline, it has to be very precise, okay? Like it is 2 weeks, specifically given by in the guidelines that we have to give MNT for 2 weeks and then we have to reassess it after 2 weeks. So say like 1 to 2 weeks, there is no such thing, just 2 weeks.
Okay, ma'am.
Okay. So it's more than one, like 2-hour value is more than 140. Okay. We say like it is positive and we will keep them, we'll label them as gestational diabetes. If it is less than 140, then
we will have to reassess them again at 32 to 36 weeks.
No,
sorry, ma'am. This is it. We have to reassess them at 24 to 28 weeks first.
Why 24 to 28 weeks?
Oh, yes, ma'am.
Why we are doing? We have chosen
because we are
24.
expecting gestational diabetes to occur at that time, ma'am.
Why it will occur at 24 to
Ma'am,
28
the
weeks?
pancreatic reserves meet the
the maximum insulin resistance and
happen.
the placenta become for total all the hormones everything start increase after 21 completed weeks of pregnancy and as always the pregnancy is a diabetogenic state and all the hormones will be increasing then and the insulin resistance will be at maximum during 24 to 28 weeks. So again, if any possibility of developing gestational diabetes is there, then that is manifested at 24 to 28 week of gestation. That is the reason why we will reassess at 24 to 28 weeks. If suppose if she is having the value more than 140 at that time,
then she is considered to be a gestation case of gestational diabetes, ma'am.
If it is less than 140,
then we have to reassess her at 32 to 36 weeks again, ma'am.
Does the guideline say so? No, unless no features of diabetes occur, like polyhydramnios is not there, there is no increased weight gain, like estimated fetal weight is not increasing, then we have to consider and manage it as a normal ANC only. That is, if you have any clinical features suspicious or any values, like when you are doing the terms investigation, if anything is suspicious of diabetes, then we have to do that. Unless otherwise, we have to consider it as an ANC. Okay. The protocols has to be said as such. Okay. Then, but then in the first trimester, as you have said, you have done all these investigations. So one more thing that we have to be very keen on. The NT-NB scan.
NT scan.
Yes. What are the soft markers that you can see in NT scan if there is any congenital anomalies which are associated with diabetes?
Ma'am, no, nuchal translucency, the nasal bone changes. Then
what are the soft markers that you will see? There are now we are discussing like more these conditions can be seen in case then over diabetes. There are cardiovascular changes can be there, neuro changes can be there, skeletal-muscular changes, and the renal changes. All those can be there. In the level 1 anomaly, what the NT-NB scan is known as the level 1 anomaly scan. There we can see like echogenic foci on the cardiogram or there can be neural tube defects. Because of that, the NT will be increased, nasal bone might not be there. It is seen both in cases of Down syndrome. The features are same and also in cases like aneuploidies and also in overt diabetes conditions, this can be seen. And after this, one more thing we will do. What is that?
Double marker test should be had.
Double marker, what you are supposed to, what is supposed to be elevated if there is any neural
beta HCG level will be elevated and
definitely beta HCG level will be higher at this time of pregnancy. It is already a pregnant patient. We are more concerned about neural tube defect. Then it is alpha fetoprotein. AFP will be elevated.
Okay.
AFP will be elevated in the double markers. That is also a sign that the baby is having a neural tube defect. Okay,
Okay.
the first trimester is completed. Now coming into the second trimester, there are two things which is very important in the case of diabetes.
Second trimester, we have to look for the anomaly scan, ma'am.
Detailed anomaly scan we have to have. So what are the things that you might see in this if it is an over diabetes? What are the features that you will see? This is the
Diabetes.
level 2 anomaly scan. Level 1 is the one which we are doing in 10 to 13 plus 6 weeks. And in this time, sorry,
It is
11 to
18 to
13 plus 6. What is
18
the
to 20.
ideal time? Yeah, what is the ideal time that you have to do in case of an over diabetes? We say it is 20 to 24 week is an ideal for an anomaly scan, but in case of over diabetes or the diabetes patient, which is the ideal time?
Earlier 18 to 20 weeks, ma'am.
Yes, we have to do an early anomaly scan. Why we are going for an early anomaly scan?
Because the chances for anomalies are congenital anomalies are higher if it is an over diabetes. So in
Hmm?
case we have to terminate the pregnancy, it would be safer to do it before 20 weeks, ma'am.
Because the difficulty to the mother will be less. Suppose if it is after 20 or 22 weeks, we go to the cutoff for 24 week, then we have to go for the troubles of medical board, everything. So better we will do at 18 weeks and we'll have an 18-week anomaly scan. We will thoroughly evaluate two systems mainly. The skeletal-muscular system, the kidney and the other features, and also the heart. What is the most common cardiac defect in case of diabetes?
Most common is a ventricular septal defect, ma'am.
I have to say it is cardiac cushion
Cardiac
defect.
cushion defect. Cardiac cushion defect.
Among that, which is the most common?
Ventricular septal defect.
Ventricular septal. But which is the most specific cardiac defect in case of diabetes?
Position of great arteries, ma'am.
Yes, transposition of greater vessel. That is more specific. If it is there, we have to suspect that the mother might have a like over. It can be seen in other cases also, but the question is like which is the most common? Then it is the endocardial cushion defect, and most specific is
Most specific is transposition of great arteries.
Okay. So musculoskeletal, what is the thing that you are expecting?
Caudal
What are the
regression.
musculoskeletal anomalies associated with diabetes?
Sacral agenesis.
Sacral agenesis, and one more is there. This is also very specific. Caudal regression syndrome.
Caudal regression.
Yes, this is very specific. And in renal anomalies, which are the one?
Renal agenesis.
Renal anomalies, which are the ones? Yes, renal agenesis and
renal agenesis. Renal dysplasias, ma'am.
no. Cystic kidney and duplex ureters. Those are rarely seen, but mainly it is the renal agenesis. Then this one, neural nervous system. Yes, neural tube defect it is, which is the neural tube defect it is commonly seen, like
spina bifida, ma'am.
Spina bifida or an anencephaly can be there. Yeah, hydrocephalus can also be seen. Then which is the other miscellaneous thing, like in umbilical artery, umbilical cord, what you will see? Renal agenesis is there, then usually it will be associated with a single umbilical artery. Yes. Then orofacial defect like cleft palate, cleft lips, all those can be seen. Okay. Okay. Then one more thing is very mandatory for when in case of diabetes for the patient. What is that?
Ma'am, in case of second trimester.
Yes.
Is it like that?
Yes. One more investigation that you are supposed to do. It is a fetal 2D echo. As we have said, there is five-fold increase in chances of getting cardiac disorders. Then you have to get a 2D echo done for the fetus. And what is the ideal time to do a 2D echo?
As early as and after the anomaly scan, ma'am.
Not as early as it is 24 week, 24 to 28 week. That is the time when the cardiac window is we can visualize that. We can look for any anomalies or any cushion defect, any flow anomaly, anything is there that is better visualized at 20. You will do from 22 to 24 weeks, but ideally 24 to 28 weeks is fine. After that, the baby grows in size that the cardiac window will not be that prominent. Okay. Yeah. Then the patient has gone into third trimester. How it is? Till now, the values are all like you have identified her as a GDM patient. 2 weekly, you have done the FPS, PPPS value. All are normal. Then the patient has moved into third trimester. Then what is next?
Serial growth scans has to be done, ma'am.
Yes. Why? We are more concerned about that.
About the polyhydramnios.
When will be the maximum fluid will be like how the polyhydramnios is maximally manifested at? When will be the Likert volume maximum?
36 weeks.
No, it is 32 to 34 weeks. Why? After that, it will start to decline. From the time of, as in the initial pregnancy, it will keep on increasing and the maximum will be at 32 to 34 weeks and then it will start to decline. And after 40 week, it will be the reduction will be very high, but till then it will. But in case of polyhydramnios, when you are doing a 32-week growth scan, there will be more. But there are some cases where the baby is having a posterior urethral valve, all those conditions. This in normal pregnancy, in such conditions, the value can be less also. But maximum values are usually seen at 32 to 34 weeks. But in diabetes patient, that will be continued throughout. Okay, well, how will you diagnose polyhydramnios? What is the cutoff for polyhydramnios?
Ma'am, a single deep pocket, 2 to 8 centimeters is normal, and amniotic fluid index, 5 to 25 centimeters is normal.
So in polyhydramnios, it will be more than that.
Yes, ma'am.
Okay. Then how will you? Then 32 week you have done an obstetric growth scan. Only obstetric growth scan will be done then, or anything you have. Yeah, or in Doppler, what you are suspecting?
Doppler flow for metacerebral artery and umbilical artery flows. We have to see if there is any uteroplacental insufficiency, ma'am. It is
When in diabetes condition, is it very common to see uteroplacental insufficiency?
No,
Why? Why? See, diabetes usually it is associated with preeclampsia features also.
Yes, ma'am.
So there are chances. It is not because of the diabetes as such. It is because of the associated features. If vasculopathy is there, then there are chances of uteroplacental insufficiency. If there is preeclampsia or hypertension associated with that, then there is chances of uteroplacental insufficiency. Yes. Then you have done the Doppler. Then again, how will you evaluate? You have to continue the pregnancy till the time you are planning to terminate.
We have to have from 32 weeks, we have to go for antepartum fetal surveillance.
What is antepartum fetal surveillance?
In this case, it is non-stress test plus biophysical profile. So,
what are the components of biophysical profile?
Fetal breathing movements, fetal body movements, fetal tone, then amniotic fluid index, and NST.
Then what does modified BPP?
In that, we consider only AFI and NST.
Yes. So what are the things how will you classify NSTs? What is the most common things that you will see in a diabetes mother non-stress test? The beat-to-beat variability is usually reduced. What there are some features in an non-stress test. What are they? We have to look for beat-to-beat variability, the baseline heart rate, accelerations are there or not, decelerations are there or not. Usually when we are seeing a diabetes, like diabetes uncontrolled mothers, the beat-to-beat variability will be usually less. So we have to be little concerned about that. From what period of gestation we do this NST?
28 weeks, ma'am.
Till 32 weeks, the parasympathetic supply of the fetus is not completely functional. So till 32 week, usually the beat-to-beat variability acceleration will not be proper. After 32 weeks, we usually get that, and 34 weeks after that, it is very ideal. So before that, we usually go with the other biophysical profiles, and after 32 week of gestation, we go with these features. So suppose the patient is polyhydramnios with history of cervical encerclage with uncontrolled diabetes mellitus, then there might be a chance of patient we have to terminate the pregnancy. Or suppose the mother is going into DKA or such conditions, we have to terminate the pregnancy. So what are the precautions that you will take in those ladies who are coming to you at 30 weeks?
30 weeks, ma'am.
Yes.
30 weeks.
She has polyhydramnios, she has cervical incompetence, uncontrolled diabetes, and she is getting all other features. Then she comes to you at 30 weeks. And when you did the PV or something, PV, then you found that she might go into preterm labor, then what you are supposed to do?
Ma'am, we have to protect her with antenatal steroids, ma'am.
First, you have to admit the patient.
Yes, ma'am.
Yeah, we have to counsel them, get the patient admitted. Then
we have to admit her and to the serial NST. We have to do the antepartum fetal surveillance more frequently. Get her sugar values under control.
when you're saying about the management, first say the
Antepartum.
investigation. Yeah, first what you will do clinically, what you will do by investigation, and what are the other interventions that you're taking. So since the patient is here, we will counsel them and we will start her on what? She's 30 weeks. She might go into immediate preterm labor. Then what you have to do?
Steroid, ma'am, antenatal steroids.
Steroid. Which is the ideal steroid to be given?
Betamethasone, ma'am. 12
Diabetes
milligrams.
also.
Ma'am?
In diabetes also, steroid, betamethasone is the ideal one. Okay, then.
We just have to consider the insulin insulin titration at the time of steroids, ma'am.
That is fine. That is the management of diabetes. I am asking about the precautions that you have to take. Anyway, you have to manage the diabetes for sure. There is no doubt in that. But for the baby, what you will do? She is 30 weeks, till 29 plus weeks. Till 30 week, we have to give lung protection and neuro protection. So lung protection, what we are giving is steroid like betamethasone, 12 mg, 24 hour apart. We might give 2 doses, or dexamethasone. We'll give 12 hour early. Yeah, 12. We'll give 4 doses. Both of them will be around 24 milligram has to be received for the patient. And we also have to give neuro protection by 30 week. After till 30 week, the brain has to. For that, what you will give?
Magnesium sulfate, ma'am.
Magnesium sulfate. You will give 4 gram bolus, 20% bolus, followed by 1 gram per hour for 24 hour. You will give that magnesium sulfate. Okay. If it is past 30 week, then we have to give only steroid coverage. Till what time you will be giving? RCOG says like till 36 week, it is ideal to give. But some ACOG says like we have to give till 38 weeks also, because in case of diabetes, the lung maturity will be having 2 weeks lag. The lecithin production will be, the surfactant production will be little more lesser. So in that condition, it is better to give. But RCOG says that if you are giving steroid in later stage of pregnancy, it can cause ARDS also. So that is little questionable, but whichever one you are taking, quote that and say accordingly. So you have to give the protection. Then you have to manage the diabetes part and the other fetal part, everything. Okay. Then again, after 32 week, you have to do a scan at 36 week. And ideally, it is 38 week also you have to do. Because there are chances like fetal weight can be increasingly high and the baby is going into more of macrosomia, then you cannot wait till that term. Ideal time to terminate, if it is controlled, is the diabetes
40.
control. What is the ideal time to terminate?
Controlled and not on medication, 40 weeks till 40 weeks we can go, ma'am.
Will we allow them to go post-term?
No, ma'am.
There are chances of sudden IUDs. Okay, if it is on medication, then
38 weeks completely.
completed 38 weeks. If the mother is having these conditions are worsening, then we can terminate earlier
Anytime.
also. This is the mode of termination.
Preferable mode of termination is vaginal delivery unless
there is any obstetric
other
indication
obstetric
or other
indication.
comorbidities which are not allowing them to deliver vaginally.
Yes, ma'am.
Okay. So on about medication, you have said you will give medical nutritional therapy initially. How you will give medical nutritional therapy?
In terms of diet, ma'am, we have to consider her to take 30 grams per 30 grams per day of carbohydrates. That is, for if we turn it into percentages, 40% of the of her diet should be carbohydrates. 20% should be proteins, and another 30 to 35% fat, ma'am.
I am a very simple lady who is coming to your OPD. I am very not much educated. I don't have any weighing machine in my home. How will I know it is 30%, 40%, 20%? I
Ma'am,
have a plate with me. Just explain to me how you will ask me to divide my plate.
Ma'am, we first daily diet can be turned into 3 meals and 3 snacks. 3 snacks are the ones which we as an add up to the splitting the meals. Ask her to take small, frequent meals, small quantity
Yes.
frequent meals, and
Okay.
includes more of dietary fibers. So that her glycemic spiking will be less, and ask her to increase complex carbohydrates like wheat, or if possible oats, like that. And then ask her to take simple fruits as snacks and
What
nuts.
is simple fruits then?
Apple, one
So
orange.
when you are advising them on medical nutritional therapy, you have to be very specific on these are the things that you can take and these are the things that you should avoid. Refined flours, atta, all those things you have to avoid. Whole wheat, multigrain, complex millets, ragi has to be increased in case of carbohydrate. In case of fruits, then the sweeter fruits like mango, sapota, all those things has to be reduced, and fruits with less glycemic index like guava, then what else?
Green apple.
Cucumber, yeah, apple with that, not the green apple one. All those things has to be increased, and the berries can be included. And about the fibers, like if you're asking them to take fibers, all these kind of amaranthus, whichever leaves they are getting, they will take. They have to take such a fibers which are little more easily digestible. And so if it is a plate, I am a person who will be going to the kitchen and taking the food, then I have to divide my plate into 3 components. Half of the plate should be filled with fruits and vegetables and the fibers. Then 1/4 of this should be proteins, and 1/4 should be, before it was 1/3, 1/3, 1/3. Now it is ideal to take it as half and 1/4, 1/4. So 1/4 should be proteins and 1/4 should be carbohydrate. And when you're seeing this, there should be some dietary products also, and there should be this fruits, or like 10% of, or including everything, there should be some fat also. Fat should not be much higher. So we have to make sure that the person is taking everything. And when you're saying them, you have to split your meal. They don't know how to split the meal. Tell them that if you are hungry enough to take 1 bowl of rice, don't take everything together. Like half of that you take at one time, then give a space for that and then take the other. Because we don't want to bombard our system with much of the carbohydrate. And when we are saying them to take a snack, then between the bigger meals, there should be a gap of at least 4 hours. And between the meal and the snack, there should be a gap of 2 hours. So when you're counseling them on medical nutritional therapy, we have to be very specific. Then only that will be effective. Otherwise, since the patient is diabetes, they will take something. In this patient also, she is having dietary deficiency. Is it good enough for a patient already on pregnancy with all these diseases to have a dietary deficiency? No. We have to give them the required amount. Required amount has to be taken. Otherwise, the fetal growth, the mother health, everything will be affected. And during postpartum period, she will have problem in healing and uterine involution. Everything will be having problem. Okay, so that is how you have to advise them on medical nutritional therapy. So if the medical nutritional therapy fails, what next?
If the medical nutritional therapy fails, we'll have to first we can start on oral hypoglycemic drugs if she is not near term. We prefer metformin. Around 500 to 2000 grams we can give metformin.
Why metformin?
Metformin will decrease the insulin resistance, ma'am. And
It is an insulin sensitizer. Okay. Yeah, so that will help the body to utilize our own insulin.
Okay.
So how you will ask them to take before food, after food?
After food.
After. And then?
After food, morning and evening. If it is split, better to split the doses and take in the morning and after food at night also.
Okay. Then only metformin is there?
Then there is glibenclamide, but it is not usually given because of risk of neonatal hypoglycemia. And
we are not sure about the findings as such. Okay. Otherwise, we'll go for
metformin.
Metformin. Okay. If oral, for every patient will be started on OHA, like if MNT fails? No. If the patient is uncontrolled, very severe values are obtained, then we have to switch on directly to insulin therapy. Or the mother is already found out to have any retinopathy or any nephropathy, mild changes or anything, vasculopathy, anything is there, then we have to switch on to insulin therapy directly rather than starting it on OHA, then converting it to the insulin. Otherwise, if the OHA is also not under control, then we on OHA, if it is not under control, then we have to go for insulin therapy. Okay, how you will give insulin?
Insulin we give her as for pre-meal insulins, ma'am, and bolus insulin. Anything.
How much you will start on?
Ma'am?
On what value you will start insulin? If the value is more than this much, you have to start the patient, do this much dose. You know about that? Yeah. If it is usually when the patient is having 140 values always, then we have to start the patient. There are two criteria. Like we have to look for both the pre-value, like fasting value, and the postprandial values also. We want to keep the insulin fasting value less than 95 and postprandial value less than 120. Okay, that is the ideal thing that we are trying to keep it. So if the postprandial values are always less than 120, we can continue the MNT. But if any of these values are more, like fasting is more than 95, then we have to increase it into insulin. So what we are doing is that initially we will start with 4 units of insulin. Like we will give mixed start. Mixed start include both intermediate and the regular insulins will be there. That we have to add in 4 units. Then we will value again. Suppose if the fasting is less than 95 and it is less than postprandial is less than 120, we will continue on the same value. Suppose if fasting is less than 95 and postprandial is more than 120, like one value is less normally and another is increased, then we will increase by 2 units. If both of them has increased, then we will increase it by 4 units. So we start with usually 4 units. One value is deranged, then we add with 2 units, and both the values are deranged, we will add with 4 units. Maximally, we can give accordingly till we get ideal value. And if the patient has to use more than 20 units of insulin per day, then she has to be cared in a tertiary sector hospital with multidisciplinary approach only. So this is how what we can manage clinically, like when the patient comes to us. Okay, these cutoffs has to be remembered. You have to remember all these values, like values, what is the ideal value. This is the DIPSI guideline, what I am talking about, how the Indian system is telling. Okay. Then, again, you will reassess the patient after how many days. If patient is on insulin, you have to reassess after 3 days.
Okay.
And we have to stabilize the value because we have to keep on increasing this till we get a normal value where the patient can be either kept at hospital, or we can, if it is uncontrolled, we have to continue the hospital monitoring. If the values are becoming ideal, we can send them home also in the initial period, like not in term or something. Okay, so this has to be monitored. Admit the patient, we will start on the insulin, we'll monitor the value every third day, and we'll find a value which is ideal for that particular patient, and we will send them. Then again, weekly, we have to reassess the patient. Okay. Then patient is on insulin. Then patient comes to you. You are planning to terminate. Okay. Now its patient is going into vaginal delivery. You are planning to her. So what you will do at admission? What time you will call her? How will you proceed?
Ma'am, at 38 weeks, we will call her for the termination of pregnancy if she's on insulin. Then
Yeah.
first we will assess her for any cephalopelvic disproportion, because if the fetal weight can be more, we are expecting if it is a gestational diabetes case. Then
So how will you get the suspicion that the patient is having a cephalopelvic disproportion? What give you a suspicion that this baby is larger? First of all, when you're seeing the baby, the abdomen itself, it will be
distended, ma'am.
over distended.
Over distended.
Then it can be because of polyhydramnios also. Then while you are doing all your maneuvers, you get an idea of how it is. Then when you're getting the presenting part, you will see whether it is engaged. Usually
Engaging.
at 38 weeks, in case of primaries, it usually goes there. If it is unengaged, then again you get the suspicion that it is a macrosomic baby. Then you have some other tests to do, like abdominopelvic. Like you will do abdominopelvic examination and see whether you can put the just engage the baby. You can bring the head down to the spine or not, or if it is overriding. There are some methods for that. Please read on to that. If I go into that, the CPD discussion will continue. So I'm not going into that. There are some tests like abdominal examination. There are finding abdominopelvic examination. There are finding, and pelvic examination also. There are finding that CPDs are there. But the ideal time to assess CPD is in labor, because that particular baby will go through that particular pelvis is what we have to find. Sometimes during the time of labor, the maternal pelvis will be little more relaxing, and the baby can have molding, and they will change the position, and they will try to come through that particular pelvis. So in labor, if you are giving a trial of labor, the diagnosis of CPD, unless there is a gross difference in the baby's head or the baby's fetal part and the pelvis, the final decision can be done only in time of in labor. Then we'll make the decision. But we have to be very thorough with that, because we don't want to have an obstructed labor or arrest, deep transverse arrest or anything like that. So study all the features of CPDs. Okay, yeah.
Okay.
Then, okay, now you have admitted the patient. CPD is not there. Patient is having a well-controlled diabetes status. Then what next?
Then we can
You are
induce
planning that tomorrow you are going to induce the patient. Okay. Then what?
first night dose of insulin we can give her, ma'am.
Okay.
Then morning dose of insulin has to be skipped, and start her on IV fluids. IV fluids with the main line of NS, we piggyback the dextrose, 5% dextrose, ma'am.
Is it mandatory?
Ma'am, in her labor process,
Are you keeping the patient nilper orally?
no, ma'am. Yeah.
What is the so it is like if you're not keeping the patient nilper orally, you can monitor the patient and decide whether she wanted dextrose or not.
Okay.
Because labor itself is a stressful event, all the stress hormones, the cortisol, everything will increase, and they will have hyperglycemia. So better if the patient is taking orally, she is comfortably progressing. It is not mandatory that we have to keep the patient on IV lines. But suppose the patient, you have a suspicion whether you have to take the patient for a C-section. If it fails, you are giving a short trial, or the patient is not willing for trials, then that time you can keep the patient NPM. Okay. Then you will keep the patient in the labor room. You have induced the patient. Then early morning, you have to check the glucose. Like the GRBS has to be monitored. Then after that, How
If it is
frequently you will check her?
if the patient is on high requirement of insulin, like more than 20 units, we'll have to check every hourly, ma'am. If it is a well-controlled diabetes, then 4-hourly insulin, 4-hourly checking would
In
be enough.
active labor, it is hourly, and in latent labor, it is 2-hourly. And ketone body, urine ketone bodies has to be checked every 4th hourly. That is the mandatory protocol. If it is the patient is already on insulin, which is very more than 20 units, then hourly you have to check it. So there is a difference in that. Okay, yeah, continue. Then you have induced patient is progressing. Then during labor, anything you have to be taken care of. Preparedness. You are suspecting anytime shoulder dystocia can happen. You have assessed only the fetal presenting part. Now you are not so sure about the shoulder. If by scan, if every the diameters are higher by if it is possible, if you are getting the diameters are higher, then you can suspect shoulder dystocia. But sometimes you might not be able to find that. Then clinically you have to be prepared to deal with the shoulder dystocia. Yes. And in labor also same, you have to continue monitoring the GRBS of the mother and see whether she is going. There can be chances that mother is in labor, she might be exhausted, she can go into hypoglycemia. In such condition, you have to keep her on 5% dextrose. Okay, in labor, what are the things you have to be very careful?
We should keep a partogram to see if it is going for a failed.
Are we using partogram now, or what is the ideal thing that you should have?
Labor.
Yes, WHO labor care.
WHO.
Then after labor, patient is on table, fully dilated, second stage pain. Then
early give liberal episiotomy so that the baby is released. Early blood cord clamping should be done to prevent polycythemia of the baby. Then neonatal care should be given properly, ma'am.
Baby is not delivered out yet. The patient is in second stage. You have to put liberal episiotomy. And if you are suspecting any kind of shoulder dystocia, what is the precaution that you have to take?
Fundal rush, suprapubic pressure has to be given.
No, you have to keep the mother's leg in abducted position. Because that gives a more space that you initially itself you can keep, and then you will go for delivery. And if you, what is shoulder dystocia?
Shoulder gets behind the pubic symphysis.
Definition, proper definition. Not delivery of the shoulder even after 20 seconds.
20 seconds of delivering the baby.
Delivery of the head. Yes. Okay. Then there are so many. There is drill for shoulder dystocia, like helper, call for help, abduction of the leg, suprapubic pressure, all the maneuvers that is there. And also there are some maneuvers to do this. Macrobots, all those maneuvers. So if the case is this, they can ask about these questions also. Read about all those maneuvers. There are named maneuvers on that. And in you are DNB, right? In DNB, when we are getting the pelvis station, there they will give you the fetus and the pelvis, and they will ask you to show the shoulder dystocia. One station itself is in case of MSMD examination, they will be just asking you only usually the delivery of the head and all. But in DNB examination, the questions can be one pelvis will be kept and they will give you a baby and they will ask you to do demonstrate shoulder dystocia. Okay, so be thorough with the fetus and the dummy how to deliver the same.
Okay.
Okay, the first thing you should say is call for help. The senior obstetrician should be there, call for everyone's help, the pediatrician should be there, then you have to do all the maneuvers. Okay, now the baby is out. Again, there are some things that you have to be very careful about. There can be placentomegaly in it also, when there will be difficulty in delivering the placenta. But don't try for manual removal or anything so abruptly, because there is chances of endometritis in case of diabetes patients. So we'll give all the third stage, that AMTSL, acute management of third stage of labor will be given. We will be delivering the placenta. Make sure that the uterine cavity is empty. Why? Because any retained product of conception in case of diabetes can lead to infection, sepsis, and septicemia for the mother. Okay. Then now the delivery is done. You have secured the episiotomy, all done. Then what next? All done? Nothing else?
Antibiotics should be given, ma'am, for
We will be giving her 1 dose of antibiotic before any surgical. You have given the episiotomy. Before that, we'll be giving 1 dose of antibiotics. That's fine.
Okay,
The
ma'am.
breastfeeding should be initiated as soon as possible for a diabetes mother, because baby can go for hypoglycemia. That is one thing. But the pediatrician will be checking the baby for any anomalies or anything, or the sugar will be checked. And as soon as possible, like within 30 minutes, ideally within 15 minutes, we have to start on breastfeeding. Or suppose baby is sick, let it be. The baby will go into the NICU. All those things are fine. Again, you have to continue monitoring the GRBS of the patient. Till 4 hours, mother can go into hypoglycemia.
Hypoglycemia.
And there can be increased hyperglycemia can also be there, and there are chances of decay can be there. And this lady can have polyhydramnios, so the chances of amniotic fluid embolism is very much higher. So the patient has to be observed very keenly during the postpartum period. The immediate postpartum period. Okay, then 4 hours you have observed she is not having higher values or anything. Then you will, what next? Patient will be shifted to the ward or whichever place she is in. Then when you will again check the sugar status.
We'll do it 6 to 12 weeks now.
No, till 6 weeks you will leave the patient like that. Ideally, 72 hours postpartum, you have to do the FPS and PPVS of the mother. Then again, after that, if it is not normal, you have to continue the insulin therapy. Some of the mothers who are diabetic in the pregnancy, they continue to be diabetic after the pregnancy itself. So you have to check on that. Then if it is normal, then you have to do a reassessment after 6 weeks postpartum. If everything is fine, only you will leave her till 6. Otherwise, the mother can get subinvolution, infections, everything, the non-healing of the wound, everything, and mother can go into other complications of diabetes. And during labor, you have to be very careful. Some of them develop retinal detachments also in case of severe diabetes patients. Not only in preeclampsia, also in case of diabetes, this can happen. So finally, the patient is all done, everything good. Then she came to you at 6 weeks postpartum. She was diabetes, GDM on insulin, now controlled, everything is fine. What is the next thing that you will do in when she comes for post 6 week checkup?
If the perfume is all,
6 weeks
everything is yes. So next, the counseling, this
you have to counsel about 2 things. One is family planning and what she has to take during the preparations during next conception. Because she might not come to you in the next pregnancy, they might change the place, anything can happen. So 2 things you have to counsel them. What are the things?
Family planning, use of contraceptives methods, we can tell her, ma'am.
This is the ideal contraceptive.
Progestin only pills.
Why? Why pills? Why she can't have any other contraceptive method?
We can
you can give her barrier method. You can advise for low dose OCPs, not in severe neuropathy or nephropathy. Severe over diabetes, better to avoid low dose OCPs because there are chances of embolization. All those things are there. Then you can ask for progesterone only. You can give her DMPA. You can give her copper T also. Before it was said like a patient should not be given copper T. Infections are more. But now it is not And even some patients who are already having heavy menstrual flow, you can even give Mirena or Emily, anything like that. Is it contraindicated to give PPI-UCD?
No.
Postpartum IUCD, is it contraindicated in diabetes mother?
No, ma'am.
Unless there is no chorioamnionitis or any previous history of any problem with IUCDs, it is not contraindicated. You can give soon after the delivery itself. When after C-section also, you can put the PPI-UCD for them. And ideally, if she has completed the family, go for a interval sterilization or postpartum sterilization, whichever is possible for her. If it is C-section, you can do concurrent sterilization also. So what is the counseling that you will give for an extra pregnancy?
Ma'am, to take preconceptional folic acid to keep the diabetic control in modest levels, so that to keep checking the sugar values every 3 years at least to
That is
make
the
sure.
most important thing. Like if once a patient is gestational diabetes, there is more chances of becoming
Risk of
diabetic in the near
yes.
20 years. So they have to have a frequent, like they have to monitor their diabetes status, and if they are planning to have a next pregnancy, tell them that in the next pregnancy also there are more chances of getting diabetes, so they have to be careful. They have to have a good diabetic control. They have to take this the conceptional folic acid, all those things, everything has to be counseled. If she has so much complications in the pregnancy, better counsel them for not to have a, but that is their choice. So you have to tell them, they have to make a informed decision. You have to counsel them regarding all the risk and consequences associated with this, and let them make an informed and an ideal decision on this. Okay. Now, so I hope we can conclude the discussion if anything is not left.
So that was an elaborate discussion. Is there any queries anyone want to ask? You can unmute and ask.
There are some things that we haven't discussed.
Good evening, ma'am. I
That
have
is
a
more of,
question.
yes.
No, that was Janani, any question?
The part of
Actually, your voice is breaking.
Your voice is
the
breaking.
present pregnancy circulage was mentioned.
Yes.
Sorry, am I audible now, ma'am?
Yes, yes.
Okay. So in past obstetric history, actually circulage was done during this present pregnancy was mentioned, but then on the next line it that antepartum, intrapartum, and those were normal. So is it okay if
We don't put the circulage. Is that your question?
no, ma'am, is a circulage is actually a significant event? Is it okay if we say that antepartum was uneventful, or we should just
I am not clear with your question. Can you just ask it again?
So what I just clarified, Dr. Aishwarya, what she was asking is, there was history of circulage done, but it was mentioned that first trimester, second trimester, and third trimester was uneventful. So she was writing, can we write
Yeah.
like that? That was the question.
In about the previous pregnancy, right? Actually,
yes,
if that was a history indicated circulage was done for that girl. So history indicated it is actually uneventful only. If there is a preterm chances, if you're putting like USG indicated or emergency indicated, emergency circulage was done, then that is an event. This is like you have done it because of the history. So the pregnancy is uneventful, but because of the previous history, you have put it. You can mention about that, but the pregnancy as such was uneventful. You are clear?
Okay. Yes, ma'am.
Yes.
Thank you, ma'am.
I think we had an elaborate discussion. Thank you, Dr. Aishwarya, for accepting our invitation and giving an excellent moderation for the case. And thank you, Dr. Haifa, for bringing up a good case for discussion. And thank you, Dr. Shubha, for being moderating this session. Thank you all the attendees for this session. And we hope to see you next month with another case presentation. Thank you so much.
Thank you all.
Thank you all.
Thank you.